Guys, I might draw everybody's attention and do a little announcement. Hi, welcome. Welcome to our last session of FDS Friday. Thanks for joining us today. And thanks for everybody really participating in FDS in our new and crazy way this year. We're going to turn it over to our presenters here very soon, but there's a question in the chat to kind of get everybody started, a little icebreaker. So if you want to look in the chat and you can kind of reply there. And if you don't see it, you could also put that in the chat and we'll write it again, but it should be popped up. And we'll get started real soon.
Oops, send it to just one person.
Should go on mute. You can hear me typing.
Looks like we're at time. Should we get started?
Yes, that sounds good.
I think so. Let's do it. Go for it, everybody. Thank you.
All right. Thanks so much, everybody. Hello, everyone. I'm so excited to be with you all here today. Thank you so much for joining our session. My name is Monica Stretton. I'm a fourth-year medical student at the University of California in San Francisco School of Medicine. I'm applying into OB-GYN right now, so I'll be one of your colleagues soon, hopefully. And one of our other people who worked on this project and presentation with us is named Jay Bindman, who is a third-year medical student at UCSF School of Medicine as well. And they were not able to join us today, but we wanted to acknowledge them and all of their work that was really critical to this project.
And hi, everyone. I'm Naomi Stotland. I'm faculty at UCSF in OB-GYN. And one of the hats that I wear is as co-director of a preclinical course called Life Stages, which includes a lot of OB-GYN content. And I learned so much over the last couple of years as our student activists and advocates have really pushed us to make our course and our language and content more gender inclusive. So this session is just sharing what we've learned and worked on over the past couple of years.
And we just want to kind of make it really explicit that we are in no way saying that we're experts in this field. Nothing that we say today is final word on anything. But we just really want to share our experience in trying to make things more gender inclusive and to actually show have representation of transgender and gender diverse health, as well as kind of share how we navigated bumps in the road. And we're still learning as we go, and maybe we'll learn from you all today as well. And also wanted to remind you that you all have access to these slides on the Whova app that you're able to review on your own. You'll also see that we provided a toolkit for you all to take home with you to help you navigate these conversations and create these changes at your own institution. So we hope that that is helpful for you moving forward after today. And before we get started, we really wanted to just acknowledge some of the experts at our institution who are really fundamental to the work that we've done. Notably, I just wanted to acknowledge Drs. Mitzi Hawkins and Gaetan Pettigrew, who are OB-GYNs here at UCSF, who are experts in trans care, as well as some of the students that Dr. Stotland just mentioned. They were really critical to kind of having a voice and making sure that these needs were brought up.
So I'll just review the learning objectives for this session. Number one, to describe the need. Why do we need to update language and content to be more inclusive of transgender and gender diverse patients? To discuss the challenges that we face, that a lot of our colleagues are facing, to use transgender and gender diverse inclusive language, and also revising content. And describe some of the solutions that we encountered, and then we can do a little bit of interactive practice revising some of our older curriculum. Next slide. And the agenda just sort of follows those objectives. We'll start out by reviewing some of the harms caused by a lack of inclusion in our medical education curricula. sharing some of our challenges, describing solutions, etc. And we'll have some time for Q&A at the end. Next slide.
Alrighty, so in just a moment, we'll kind of get into why this work is important and kind of give you some background. But I just wanted to do a temperature check of the room and kind of see how people are feeling. You can give us a thumbs up or a thumbs down or type in the chat. We just want to know, what is this conversation looking like at your institutions in terms of creating gender inclusive curricula? Is there a lot of room for growth? Are you kind of in the middle of changing it? Do you feel pretty good about what's going on? And I also appreciate that somebody put in the chat why they joined the session. Thank you so much for answering that question. So just take a minute, tell us how you think your school is doing.
Can I come off you guys and say it out loud?
Absolutely.
So, thanks. So I teach our preclinical course in human reproduction, and we actually purposefully, in the third week of it, where we cover breast disease, tried to introduce transgender healthcare and have worked with some faculty partners on that. What me and my faculty person have realized is that we're both like in our 40s, and so we're not real facile with the curriculum we thought we created, that we thought was like novel and doing good. And so we had students come up to us and say, you know, you guys you're really trying, but you need some help. And it was really great. And you know, unfortunately, it was students who were in the course. Now they've gone through the course, and we have a whole nother year to work with them to do even more. So we're really looking forward to that, and which is why I was really looking forward to coming today.
Thank you for sharing that. That's very parallel to what I've experienced as a faculty teaching preclinical. Really was driven by student advocacy. That's what drove these changes. So thanks for sharing that. I see some more great comments in the chat. Let's see. Dr. Clay, we are just starting to review our curricula to make changes for the clerkship. Thanks for sharing that. Let's go to the next slide and we'll get into it.
That sounds good. All right, thanks for sharing, everybody. So just wanted to share some information, some background. So there was a survey of LCME accredited US faculty practices that was administered in 2015 that found that only 16% of programs included comprehensive LGBT training. They also found that 52% of programs reported no LGBT training at all. And this is just kind of for the entire LGBT community and not really necessarily even just the transgender healthcare. So I just think that's kind of some stark numbers to know only 16% of programs are even covering these topics at all. There was also a cross-sectional survey that was administered to OB-GYNs across the country in 2015, an anonymous survey that found that you know, only 1/3 of respondents felt comfortable caring for transgender patients, and 80% of folks felt that they didn't receive training in transgender care during residency. So I think that's really important to think about for this group as well. There was also a Center for American Progress survey that was administered in 2020 that surveyed many folks who identified as transgender or gender diverse of other gender identities. And almost half of respondents felt or reported having been discriminated against when seeking healthcare. And that number was actually higher for people who were transgender or gender diverse and of color. About 68% of trans people of color reported discrimination when seeking care. And 22% in another survey in the same year reported avoiding seeking care altogether because of fear of discrimination. And I think this number actually might be higher than just 22%, but this is what came out of that survey. So I think it's really important to think about, you know, what are the harms of not having, what are the harms that our patients are experiencing when they come to seek care and, you know, want to be provided for. And there was also a paper that was published in 2006 that analyzed patient interviews that found that you know, from when interviewing transgender and gender diverse patients, the most frequently reported barrier to care was access to providers who are knowledgeable about transgender health issues. And so with follow-up questions, they found that, you know, these providers were just not taught about trans care or trans health in conventional medical curricula, and that there were too few physicians who just had the necessary knowledge and comfort to care for all of their patients. There are also some papers that came out that showed that a lot of the experiences of discrimination and low quality care were related directly to gender identity, deterred transgender and gender diverse people from seeking care, kind of as I alluded to in the previous slide. But a lot of this came about because, or a lot of the discrimination and experiences they had were being misgendered by staff in the clinics and hospitals, having providers who are not knowledgeable in gender affirming care or reproductive care, and sometimes just having providers who outright refuse to care for them. And a lot of these discriminatory experiences were reported to be exacerbated by having highly gendered clinical environments. As many of us, I'm sure, have at our institutions, women's health services or women's health centers that that in and of itself can be kind of harmful, or at least exclusive to a lot of folks who might not identify as women, but still need care in the realms of contraception, abortion, pregnancy and birth, and more. And there are a lot of consequences to these harms. I think one thing that is really important is that when people don't seek care because of fear of discrimination, or because of prior experiences with the discrimination, or prior experiences of having providers who just don't know how to care for them, then folks don't seek care. That can increase the risk of either getting STIs or having complications of STIs that go untreated. They might have unplanned pregnancies or have to continue unplanned pregnancies, and they might end up developing cancer. And that's, we can think about that in the sense, or in the setting of somebody not getting access to their annual gynecologic visits to get their pap smears. It can also mean that a lot of folks end up going to what are called parallel providers to get care. So that's a term that describes folks who are not licensed health professionals who still provide some sort of care. So lay providers, as you might hear that term, and for various things that people might seek. And one of those things is hormone therapy as well, from folks who are not licensed to practice. And in addition to unmonitored hormone therapy that folks might purchase online because they want to get their gender affirming hormones outside of a setting that they have felt is discriminatory. So I think this is really important, that we recognize that these are the harms that are currently happening, and we really should help to work to stop those things. And by doing this work here, by creating gender inclusive content and curricula, we can help mitigate these harms. So I'm really glad that you're here today and we can help stop these.
Thank you, Monica, for covering the background. So now I'm going to talk about some of the challenges that I encountered, my colleagues encountered, trying to make our curriculum more gender inclusive. Next slide. So just finding alternative language. I remember when students first came to us saying, hey, you need to make some of these changes. We were like, okay, great. Where's the guide? Where's the guidebook? Where's the toolkit? We actually our institution had done some great work on anti-racism curriculum, and we had a toolkit for that, but we didn't have a toolkit for gender inclusion. So we had to kind of just look around and talk to experts. We worked with our student advocates. We worked with our local experts, and these things were a work in progress and still are. As we were coming up with alternative language, some of the substitutes we came up with or that were suggested to us felt very wordy. For example, saying person with a uterus or presumed cis women, which we'll cover some of these terms later. Some of them feel very uncomfortable because they're longer. And I think, I would love to see in the future us coming up with more codes or new terminology that will actually make communication easier, but this is a work in progress. What about when we want to cite the literature or from professional organizations? It's something on a CDC website that uses gendered language. How do we do that without and still be inclusive? So we came up with some ways to do that we'll outline later. A lot of our faculty were really on board with teaching in an inclusive way, but we're very afraid of making mistakes. And I will say a lot of our student activists were very assertive in telling us when we made mistakes, and we had to really develop a lot of humility to be able to be like, it's okay, we're gonna make mistakes and we're gonna correct it and we're gonna learn, and it's gonna be a back and forth. But that fear really was impactful. And I will say, I mean, I had people who were less enthusiastic about teaching small groups and things like that when some of these changes started to be made. So that is something that we have to plan for, as well as even pushback from faculty who don't agree with some of the changes. In terms of institutional barriers, we were lucky to have, a group of faculty that had percent effort time to develop new curricula. Our deans and my chair were all very supportive of this work. So we were given reasonable amount of time and resources to do that. I also was incredibly lucky to have Monica, a senior medical student who wanted to do scholarly work in this area and who did a lot of the collaboration with us, as well as other students. But finding time, because this is time-consuming work, can be a barrier. Next slide. How can we overcome these challenges? Next slide. So just practicing like crazy. This is a lot easier for me now than it was 2 years ago when I started this process, but it's always a work in progress. Like I said, we worked with transgender and gender diverse health experts and educators at our own and other institutions. We worked collaboratively with our student activist groups, but one of the things I really wanted to mention is, I'm sure you're aware of the term like minority tax, where when this first came to me as a task, I thought, well, I'm not an expert. I don't identify as a non-binary individual. How can I, do this work? And realize that, I can't put all the work on the people in the group that is being oppressed. I have to take action as an ally to learn and do this work. And so that's why it's important for all of us to make these changes. But I wasn't an expert, so I had to do a lot of learning. And then as we were doing this work, we continually were developing glossaries, toolkits, language guides for faculty. And one of the things, the silver linings of this, in addition to just being more inclusive, and we got a lot of positive feedback from students, but was also that we learned as we were doing this about the physiology and clinical topics we were teaching. It made us see those topics in a deeper way. And because the gender inclusive language is actually often more precise and descriptive than the old way of doing it. One of my favorite examples, I wish I had a slide here, but one of our anatomy professors redid her whole talk on pelvic anatomy to be gender inclusive, and just did some really innovative, phenomenal work with teaching pelvic anatomy. So I was very inspired by that. Next slide. So one of the things that was a big part of my work in the last couple of years was actually reviewing slides and other materials with faculty speakers and small group leaders prior to sessions. Our course, Life Stages, our preclinical course, has hundreds of faculty, small group leaders, and speakers across a variety of disciplines. And so not all of our faculty were at the same level of making gender inclusive language changes. So I really made myself, and my other co-course directors made themselves available to do revision of PowerPoint slides and other materials. Sometimes we decided to restructure a session. In addition to all of these changes, we were having COVID changes and having to do everything online. And so we made some of our small groups into large group interactive sessions, because if I felt that we couldn't get 12 or 15 small group leaders who could be up to speed on these changes, it might be better to just do a large group session. So sometimes those changes needed to be made. And then this sort of humility of making real-time corrections, even in the middle of a session, a Zoom session, we would say, oh, this slide actually has some outdated language in it. And just making an acknowledgement was really appreciated by the students and audience. So that was okay. We couldn't always fix everything in time for the session. Again, faculty development sessions whenever possible. So for example, our pediatrics block director would have sessions with all of his small group leaders beforehand to review some of these language changes. And yeah, creativity, like I'm thinking of my anatomy colleague who just did these amazing new innovative changes to her slides. And then humility, again, just being okay with making mistakes and acknowledging them and learning and moving on was really helpful. I will say that I had some colleagues that either, again, like dropped out of teaching my course, not a lot. But that is one of the challenges, and also some that just pushed back and said, I don't want to say it that way, I'm going to say it a different way. And we're all still working together to find the best solutions, but it's ongoing challenges. Next slide, please.
Alrighty, so I wanted to give you some examples of alternative language that you could use for any of the terms that can be quite gendered. And we have, examples of alternatives to the terms like women, mother or maternal, female, breast milk or breastfeeding. And I just want to, before we go into these alternatives, I want to emphasize that this language is very much patient dependent. So when I say that, I mean that it's okay to use these terms when you're referring to individuals who like these terms. So if your patient likes to, identifies as a woman and wants to be called a woman, or wants to be called a mother, or refers to feeding their infant as breastfeeding or using breast milk, that's absolutely okay. But when we're talking about people on a population level, or when we're teaching the content more broadly, that's when we need to be using gender inclusive language, because we're describing all people who have these physiologic who have this physiology or who have the needs that we can provide as OBGYNs. So I just want to make that clear before we get into it. And I also want to say, if you use women on a population scale, that's also okay, so long as you're including both cis and trans women. I think that sometimes we use women to only mean cis women, but thinking about trans women as well when we're talking about caring for women. So some examples for alternatives, it just depends on the context. So you could say patients or people. If you're saying women who give birth, you could say people who give birth, things like that. There are also some ways to describe the literature. I think this can be really challenging, and we'll get into this in a bit more in a few slides. But when reciting studies, oftentimes they refer to women, but they haven't necessarily kind of dug into the gender identities of the participants in those studies. So we say that they have been presumed to be cis women. So we can say presumed cis women or PCW, and we'll get into that a bit more later. Could also say people with a uterus, people with ovaries, if that's the important thing that you want to highlight, or if that is the important thing that makes whatever the topic relevant. We can get into more specifics later as well, but I just wanted to give you some examples. Other alternatives for mother and maternal could be parent or parental, gestational parent or gestational carrier, or birthing person. These are also terms that are more inclusive of all types of families as well, not just inclusive of all genders and gender identities. Thinking about people who might be surrogate carriers, they might not identify as the parent or the mother, but they might identify as the gestational carrier or the surrogate, or however they identify. So I just wanted to bring that to your attention as well. Some alternatives to the term female, it just, again, it depends on the context. If you are describing female genitalia, for example, I've seen this written in notes, on patient exam, female genitalia appearing normal. You can just say vulva, vagina, cervix, normal appearing. You can be very specific in terms of what you mean. Also, you will have access to this in the slides to peruse later, but some examples of how to refer to condoms, for example, there are female condoms and male condoms is how they're described, but you could call them internal condoms or vaginal condoms. There are, folks who are assigned female at birth. That's another term you could use. That just describes folks who have ovaries or uterus, or at least, I guess really it's external vulva, but who have been assigned female at birth, but maybe they identify as non-binary or as a man and not necessarily as a woman or female. And I want to emphasize that it's really important to avoid using the term biological female, because we don't really know what that means. What is the biology that you're referring to? Is it the hormones that that person has circulating in their body? Is it their organs that they have? Is it how they appear on the outside? I think or is it their chromosomes? There are so many things that could mean biology, and I think it's important to just avoid using that term. So if you, so I think assigned female at birth is an alternative as well, to avoid biologic female. And I kind of mentioned this briefly, but breast milk and breastfeeding, you could use human milk or lactating or lactation or chest feeding. And again, this is for a population level. If your patient calls feeding their infant breastfeeding, that's totally fine to do so. And so I just wanted to kind of give you some ideas of how you can be creative in using different language.
Okay, great. Thanks, Monica. So I'm going to show a couple of slides that we had in our intro to course PowerPoint in 2021. Next slide. This was from a couple of years ago when my pediatric colleague developed this in conjunction with the student advocate groups. Just a very basic slide showing that sex and gender identity are not equal. And I'm not going to go through this whole slide today, but just an example of how we introed our course with some of this content. And next slide. So this was a new slide for 2021. So we had sort of this mission statement at the beginning, or this disclaimer. We acknowledge that medical terminology can be limited, and specifically cisnormative and heteronormative, as well as recognizing the harms this causes to people who identify as sex or gender minorities. And then we outlined things that we were doing, because the whole point, this is all about humility and learning and showing that we're not perfect. We're not where we might want to be ultimately, but here's our offering to the students of what we've done so far for this year. So for 2021, some of the new changes we had made, we had a new online module, a patient interview detailing the birth experience of a trans man patient, which we'll show you a little bit about later in the session. We had re-recorded we had a lot of online modules. And one of the challenges I'm sure you've all faced is now we're doing more asynchronous learning. We're having more pre-recorded and online modules. And if they had language in them that we felt was outdated or not inclusive, did we have the tech support and the time to really re-record? So we couldn't re-record every single session, but our institution luckily did put resources to re-recording at least a certain percentage of our online modules. So we did do some of that work, but it's still a work in progress. And what I elected to do is some of those, when I rewatched them and thought, this one doesn't really add a lot anyway, I'm going to just eliminate this one and replace it with a reader chapter. So, we just sort of went through everything to decide on the risks and benefits of each outdated session. And then we told students we'd revise language and case presentations across the course. And this is something we haven't mentioned really yet, but it isn't just about changing the language, but when we are talking about small group or case-based learning, one of the things the students pointed out to us is they had actually done a survey of all the preclinical courses and looked at how many of the cases presented in small groups and other learning sessions were patients who were identified as either transgender or gender diverse, non-binary. And like in our course, we almost had none a couple of years ago. And so we rewrote some of our cases to represent sex and gender minorities, gender diverse patients. Again, we removed gendered language from reader chapters and slides. And then again, expressing our gratitude, we relied a lot on regular meetings with our student activist groups to bounce things off of them. Again, we were doing the work with our student colleagues like Monica, but the activist groups were a great resource for bouncing things off, discussing them, saying, how does this look? And then finally, this sort of statement of humility of this is not going to be perfect, but we would love your input, and this is a work in progress. Next slide. This was a slide that one of our education deans shared with us during this process that we were also able to share with some of our faculty speakers. So this is just a way to think about how to make some of these language changes. So when I'm deciding about language to use around sex and gender? Am I talking about a biological process? For example, am I talking about cervical cancer? If I'm talking about cervical cancer, then person with a cervix actually makes a decent amount of sense. Because whether or not you identify with a woman, if you don't have a cervix because it was removed after a procedure or something, then talking about risk of cervical cancer is probably not relevant to you. So really the relevant thing, biological piece, when you're talking about cervical cancer is a person with a cervix. So that was just a really helpful framing for me. Or am I talking about epidemiology risk factors again? So, and maybe I'm talking about behavioral health. Maybe the gender identity is actually what's important here rather than a biological feature. So just really sort of stepping back and saying for this particular topic, how do I want to identify my patient population? Next slide. Am I talking about traditionally gendered roles? Like this is one of the ones I struggle with the most is the term maternal. And I know all of us who trained, I'm over 50, when I trained, we would just be on L&D saying moms, moms, moms. And a lot of our patients identify as mom. I identify as a mom, and there's nothing wrong with using that for a person, individual person. But when we talk about all people who come to have babies on our unit as moms, that could be problematic because not all of our patients, as we learned from our patient interview session, not all patients that are birthing on our unit may identify as a mom. And they could feel very excluded by that type of language used universally. So talking about families, I love talking about families. Most of the time, people identify as part of a family. So we were called the Family Birth Center at our institution. Am I referencing an older study, as Monica talked about, when we're talking about referencing literature? This is one of the more challenging things we faced in our teaching. And so just being aware that some of the language that may be in older studies is not going to be up to the standard that we're using today, and just making an acknowledgement of that, either in our online materials or during a live session, was really appreciated by students. Next slide.
Yeah, thank you. So we'll show you, thank you. We'll show you some case vignettes that we updated as well. And I just kind of want to share, our objectives really were to showcase gender diversity of our patients, as Dr. Stotland had mentioned, but also incorporating pronouns and gender identity of our patients in all case vignettes. And so here at the top, you'll see the case, a case that was written or in our workbook prior to all this work that we're talking about now. So in 2020, and then the version on the bottom is the updated version that we had in the 2021 course. So not much change, but this is a case following a patient named EP, who's a 20-year-old woman who's going to a gynecology clinic for an exam. And we changed it to showcase EP, who uses she, her pronouns, who's a 20-year-old woman who goes to gynecology clinic. And so there wasn't a whole lot of change that we made, but we wanted to make sure that we were, including her gender pronouns, because that's important for everybody. And it helps normalize things for when we have folks who don't use she, her pronouns in other cases. And we included that she was a woman, but we didn't necessarily say that she was a cis woman or that she was assigned female at birth, because in this made up case, EP identifies as a woman. And I'll let you kind of read it more on your own, but there is a part of this case that shares that EP has a, is it in here? Maybe not. Oh, in the next case, sorry. Anyway, move on to the next one. All right, I got the two cases mixed up. So this is the second case. So JC, who used to be described as a 33-year-old woman who desires pregnancy, who's amenorrheic and has a cis man partner. And then in this past year, when we made our changes, we updated the case so that JC uses they, them pronouns and is a 33-year-old non-binary person who desires pregnancy and has a cis man partner. And so what's nice about sharing this case is I think the only thing that we changed were the pronouns and the gender identity, but the physiology was all the same. Everything else about the case was the same. So it was very easy for folks to continue to teach in the ways that they had prior, but just using more inclusive language and just having a non-binary person be represented, which is helpful not only for our learners and our staff and even faculty who might identify as non-binary to see themselves represented in these cases, but also so that our learners become more comfortable in thinking about and talking about patients who they will eventually see who don't necessarily identify within the binary, or who don't necessarily identify as who aren't cis gender or of this or anything of the sort. And I do want to let Dr. Stutland kind of take over a bit for one of the issues that we have actually with this case.
Well, yeah, it just really illustrates, even within our group of student advocates that we worked with closely, there wasn't always agreement amongst them or amongst our experts about what the ideal language was. So there's no right answers to this, but it's really about, it was a communal process, which I actually love. It was kind of like we worked as a community to figure out what was the language that we were all most comfortable with altogether, but not everybody always agreed. But everyone appreciated that it was a group process. So for example, cis man partner, this patient is trying to get pregnant. And what I wanted to indicate was that this person had a partner that could cause a pregnancy through their sexual activity. And we went through all kinds of alternatives, like person with a penis, or person with testes, or person incapable of causing a pregnancy. And all of those were considered and discussed. Ultimately, we put cis man in this case, but not everybody liked the term cis man or cis woman either. So just to say that it was a discussion, and it's being creative, but not everybody agreed about the optimal terminology.
Yeah. And perhaps we'll change it for next year. I think this is another example of how these documents are living and breathing. We're going to kind of be doing an annual revision, annual audit, and kind of seeing what we can improve every day and every year. Alrighty, and now we're going to show some examples from our course reader, which is our online textbook for the course. And the main thing I wanted to show, so on the left, you have the old version, and on the right, you have the new version, and all of the changes are highlighted in yellow. And we won't go through this all, we won't read it through in its entirety now, but you're welcome to review it on your own later. What I really wanted to highlight was this disclaimer at the top. I don't know if you can see my cursor, but it says note. And this is kind of how we explained that when we were referring to certain research that wasn't performed in a way that really assessed participants' gender identity, that we wanted to share that we think that these studies are presuming that all participants were cis women. So that's why we use the term presumed cis women. And this was actually because of this came out of a paper that some experts in the Bay Area who are OB-GYNs and as well as people who are experts in taking care of transgender patients, they use the term presumed cis women when referring to some of the studies in their background. And I just thought, oh, I really like that. So that's why we use that terminology this year. And it isn't perfect. I think, we've also, some people really like that term as an alternative, and some don't. Some say, oh, you should just say assigned female at birth. So this is another example that this is something that's kind of even still a work in progress, and maybe we'll change it next year, maybe we won't. But I think it also shows some of the ways that you can describe these cases in a way that is still gender inclusive, but staying true to the literature that you're citing. And then on the bottom, you can kind of see too some changes highlighted briefly, where I have woman, and then there's she, and her that are listed, and then we changed it to person, and then we just removed the pronouns. So this person with an undesired pregnancy has three options: continue the pregnancy, or have an abortion, whereas in the prior slide it said she can continue the pregnancy, she can have an abortion, she can XYZ. So another way to be creative is just to restructure how the phrase is written, and it doesn't really have to change the meaning of what's written either. Alrighty, and then this is just another example. So again, left, the side on the left is the old version, on the right is the new version, and this is just to show you how we reference the presumed cis women, or PCW, and it's showcased throughout here. And I'll let you all kind of review that on your own, but I just wanted to give you an example of what it looks like. Alrighty. And this is another slide that you can review on your own, but I'll keep it up here. Briefly, you'll see on the left, there's references to woman, she, her throughout. And largely, we just changed the terminology to say patient or person, or just kind of restructured this sentence here where it says on the left, first, her pregnancy must be confirmed. And then on the right says, first, the pregnancy must be confirmed. So another way to be creative and kind of get have the same message, get the same message out there.
And as we said, word search is your friend in making these revisions. And Monica and I were laughing about how word search is your friend, but you don't want to do auto replace, find and replace. You want to look at each circumstance to decide what the best substitution is. But at least in terms of identifying gendered language that you might want to change, it's being in the digital age is it's handy.
Yeah, definitely. Control find became my best friend for a while, and it was really helpful. But also needing to review things with a fine-tooth comb as well, because it is hard. It is easy to miss one term or one word that wasn't included in your find or your search. Alrighty, now we want to give you all an opportunity to practice the things that we've shared with you. So we have a paragraph from the old version of our reader chapter on contraception, and this is a paragraph on postpartum and post-abortion contraception. So I want to give you all a minute to just kind of read this, and as you're reading it, you can feel free to speak up, unmute yourselves, or just put in the chat what you kind of notice and maybe some alternatives that you might use or some changes that you might make if you were to edit this and update this yourself. So we'll take a few minutes here.
And I totally appreciate that many people may have to be multitasking because of the change in schedule. So we're happy to just sort of help you along with some of these. There's a comment in the chat about whether we have any thoughts about use of textbooks. We heavily use case files in our clerkship, which have not been updated to have any gender inclusive language. Other than acknowledge this with our students who are struggling with what to do, we thought about rewriting the cases, but realized that it was way beyond that from a language perspective. Yeah. I don't know if you could clarify in terms of case files, are these your own content or is this other publicly available textbooks? But I think what we ultimately did is we had a 1,000+ page online textbook, digital textbook exclusive to our course. And we just took over 2 years, we kind of did these revisions and rewrote everything, including cases, textbook content and cases. We rewrote it to be more gender inclusive bit by bit. But where we couldn't do that for a variety of reasons, we would just do an acknowledgement or disclaimer about the language. So I think everyone's going to find what works best for the culture at their institution. But for our institution, there was really an expectation that we provide content that was gender inclusive as much as possible. I don't know if that
I can't believe they have a 1,000-page textbook. That's their own. That's so painful.
I'm sorry, say that again. I heard. Oh.
I'm really impressed that you have your own 1,000-page internal textbook. That's incredible.
It was developed over many, many years by multiple authors, and that was great. But the downside was a lot of it was really out of date in terms of language. So we had to really do a lot of updating.
Yeah, and I would say Dr. Daughters-Katz, as somebody who more recently went through my clerkship, I think, I know the case files textbook is really helpful for learning. I think, as Dr. Stotland mentioned, doing an acknowledgement is one thing that I would recommend, but you could also even just create a couple of cases on your own just to supplement it. So at least there is some exposure to how to approach folks who have different identities and things like that. So, we don't always have to start from scratch. I think it's just an imperfect world. We have to work with what we are, the bandwidth that we have and the resources that we have. And so, maybe just consider adding a couple of supplemental cases that you write on your own that are more inclusive.
Yeah, because there's a lot of great teaching content out there that's not gender inclusive, that has other, so I think we would give a link to something we found on YouTube that was really helpful, but that might not have gender inclusive language. And at our institution, the expectation is that we would put a little disclaimer on it and just warn students that that's how it was. And that was really appreciated and felt awkward at first and then became kind of second nature. So because I don't want to just not recommend a great teaching resource if, at all. So that was a balance. So
so I think we can.
Yeah, go ahead, Monica.
I was just going to say
I haven't gotten things in the chat about, so maybe we can just go through it with them.
Yeah, that's what I was thinking too. So I'm glad we're on the same page. So we'll just go through the changes that we made. So on the left, again, the old version, on the right is the new version, and the changes are highlighted. And so again, we want, because it's a textbook, we're referring to populations of people. That's why we want to be gender inclusive. So on the left, there are, I highlighted women's, her, breastfeeding, women, feed, breastfeeding. And so a lot of the changes were just kind of restructuring the sentence. So the first sentence that used to say, ideally a woman's postpartum contraception plan is discussed during her prenatal visits. And we changed it to, ideally the postpartum contraception plan is discussed during prenatal visits. So little tweaks that really helped, I think. We also changed breastfeeding to lactating or lactation. Individual was another alternative to a woman. Birthing parents instead of women. And, I also became a big fan of just saying those, those who was something I really liked to use. So instead of women who are exclusively breastfeeding, I said, or we wrote those who are exclusively lactating may ovulate, or, et cetera, et cetera. So I think that's just kind of how we handled it. And I think we're really happy with how it looks. And if anybody has any comments or questions at this point, feel free to shout out or put it in the chat. I'll give you a couple seconds. Otherwise, I'll just go to the next slide.
I think the thing that strikes me here is that, again, trying to grow through this stuff and learn, like your rewrite is not clunky. You guys were talking earlier about some terminology that does get long and is maybe a little bit clunky, or it would make you stumble. This doesn't make you stumble. You could give this, I think, to anybody wherever they are on their path, and they could read this and just, it's grammatically correct and it's not confusing, and you really don't stumble with it. So I think that you did a very nice job of that.
Thank you so much for that comment. And one of the things that happened while we were making these changes, and it was COVID's going on, and I remember that Dr. Fauci came on CNN and said, pregnant people. And I just remember thinking, hey, this is already, this is going up to that level of health authority that, and I've never gotten a chance to talk to Dr. Fauci about whether that was intentional, but I'm pretty sure that was an intentional change that he was making, talking about pregnant people should get the vaccine, et cetera. So I'm very hopeful that we'll all become more comfortable with this language, especially as people in positions of prominence start using it more.
Yeah, and I think I will say that I think there are some benefits to really working with students on this, because, for me, I've only been in the medical field, or if you can even say that, for maybe 4 years, versus people who have been, practicing for decades. So it's much easier for me to think of things a bit more critically, because they're newer terminology. It's newer terminology to me than to somebody who's been using the same terms over and over again for a long time. And so I think really taking advantage of the new perspectives and the fresh eyes to be able to come up with creative alternatives is really helpful.
Yeah, thanks for that comment, Monica, because I was thinking as we're giving this talk that really this is as much about faculty learning from students as the other way around. And I think that's beautiful. Like, the learners, we have a lot to teach the learners, but the learners also have other things to teach us. And that's, I think why a lot of us love academia is because we continue to learn so much.
All right, thank you so much. Okay, well, move on to sharing some of the content that we actually created to include trans health and to really improve our knowledge of trans care and trans health so we can take care of our patients properly. So the next slide is an example that we included in the course reader, which is the 1,000-page textbook that Dr. Stahlen referenced. So we added 2 whole pages to the contraception chapter on special considerations or just considerations for transgender and gender diverse patients. And it was simpler, honestly, to kind of divide it into those who are assigned female at birth and those who are assigned male at birth. And I think it flowed really well and read really well. Perhaps we'll change it later on because I realize that kind of contributes to a binary in some ways, but we'll just kind of go through it now just to kind of give you some exposure. So I'll just kind of briefly run through this. You're welcome to read this in more detail later. But we really just wanted to share that contraception is a need for anybody who does not want to become pregnant, but has the capacity to become pregnant. And so that includes trans men or non-binary people who have functioning ovaries and uterus and engage in sexual practices that could result in pregnancy. And we kind of made it very explicit at the beginning as well that folks who are taking gender affirming hormones such as testosterone or GnRH analogs, those hormones are not contraception. And I think that's a common misconception within the medical community. And unfortunately, a lot of patients have been told by their doctors that if you're taking testosterone, that's a form of contraception, you cannot get pregnant. And unfortunately, that is not true. And some patients run into trouble because of that false education. So we really wanted to make that explicit here. We also mentioned that testosterone therapy is considered a contraindication in pregnancy, that exogenous testosterone is considered a teratogen. So just for our learners' awareness. And then we just kind of went through various contraceptive methods and why they may or may not be desirable to some folks, and kind of emphasizing that just like in the contraceptive counseling we give to any patient, there's no one size fits all method. And that's still very true of our transgender and gender diverse population. We want to make sure that we're not kind of putting anybody into a box and just making assumptions about not only their gender identity, but also how they affirm their gender. So we kind of talked about how there are some non-hormonal methods that might be desirable to some folks, that there are hormonal methods that actually are desirable and that might be desirable, I should say. But thinking about estrogen therapy, containing therapies may not be the best fits for somebody who's taking exogenous testosterone, because that might kind of counteract the benefits that they're trying to seek or what they want to get out of their testosterone therapy. But a progestin only method might be great, such as a progestin pill or a hormonal IUD, because that can not only act as a form of contraception, but can also cause amenorrhea. And that might be desirable to somebody who's, who doesn't want to menstruate. Maybe their menses creates a lot of dysphoria and a lot of, harm for them. So I think just thinking about those things as well, and kind of the added benefits that we think about for cis women too, for folks who want to have certain benefits from taking OCPs, they do that for acne clearing, for example. So just thinking about that, for this patient population as well. So again, you can read this more thoroughly later, but we were really excited to include this content.
And I'll jump in here for a second, Monica, this was as a course director, we really sat down and did a lot of thinking about the balance between, this is a preclinical course. We want to teach basic physiology, very basic clinical concepts, and yet acknowledge important issues about transgender health. And it was a balance because, we don't get into a lot of depth about transgender health. We have a lot more in the third year clerkship curriculum of transgender health. So one of the things we did message to students in the second year was, you're going to get more this content in depth in third year and in fourth year and the rest of med school. So it was always a balance between teaching the very basics, but also making sure that that we had some sort of thought about what are some of the issues, whether we're talking about breast cancer or contraception, that a patient on gender affirming hormone therapy, for example, might face. And the thing is, when we didn't do that, there was a student in the audience who would ask the speaker, well, how about, if I have a transgender patient on testosterone and, what is their cancer risk? What is this? And so we had to be ready and anticipate this content. So, but it was always a balance. Next, sorry, back to you, Monica.
Thank you. I think that's a good point. Thank you. All right, so one of the things that we are so excited about is the creation of this new online learning module that was a patient interview conducted by Dr. Mitzi Hawkins, who we acknowledged at the very beginning, but is an OB-GYN here at UCSF and really very well versed in the care of trans patients. And Dr. Hawkins interviewed a former patient of ours who is named Johnny Weaver, who's a trans man, who discussed his experience having a pregnancy and going through the birthing process. And, I think I want to pause and just kind of talk about the power that exists with patient testimonies. I think it's so important. And, I'm really fortunate where at my medical school, almost every single preclinical course had patient panels and patient interviews to help us understand what do these diseases or what do these experiences look like outside of just the clinical setting, outside of just the hospital or our office, and how does this affect people's lives? So this was kind of a nice, almost an easy thing to create because there are so many patient panels already in the preclinical curriculum at our institution. And so we kind of just leaned into it. But Dr. Hawkins, when interviewing Donnie shared with us some of the things that we talked about just a few slides ago, that he had been told by many doctors that he could not get pregnant because he was taking exogenous testosterone. And he found out that he was pregnant. And when he found out he was pregnant, he found out that he was 6 months pregnant. And so he was, not able to terminate the pregnancy. And then kind of felt forced into continuing the pregnancy and also shared some of his experiences through the birthing process that for him was very gendered, very dysphoric, and things he didn't want to experience because the birthing process and labor and delivery was so centered on the care for women or cis women, and it just wasn't inclusive for him. And I think it was really powerful for our students to hear that directly from a patient, how important it is that we create spaces that are more inclusive of all patients. And we got a lot of feedback that this was a really received very positively by our students. And I'm so grateful that we were able to kind of create this. And I wanted to see if Dr. Stotland had anything to add.
There were so many great lessons I learned from this interview. And Monica pointed out the misinformation the patient got about birth control and pregnancy risks, but also this particular patient really wanted a primary C-section because of their gender dysphoria or because of their body, particularly around parts of their body that he didn't like to talk about his vagina, and really thought it would be extremely traumatic to have vaginal birth. Ultimately was given a primary C-section, but had to really fight aggressively with providers to be offered that. So that was a lesson for me, as I would not have expected him to necessarily have had that experience. So there was just so much learning involved in getting this patient history. So I highly recommend that if you have opportunity to get patient panel. Oh, another important thing was we were able to get funds for this patient for childcare, which we sort of pooled together money, but that can be a real barrier to getting some of the most important stories that you might want to get. So I'm glad that this patient advocated for himself, say, I really need money for childcare if I'm going to do this interview. And we were able to do that.
Do people get as bent out of shape for non-medically indicated primary C-sections in cisgendered women, or were they more elevated in their opposition to his request for C-section?
Well, I don't know. I mean, I heard I wasn't directly involved in this patient's care, but I think in the Bay Area, we are very pro vaginal birth, very pro, we think we're very pro patient autonomy, and we don't have a lot of patients who ask for primary C-sections without a medical indication. And so I think there was just very good intentions, and this patient acknowledged that, very good intentions throughout his care, but just a misunderstanding really of how necessary this was for him to not have a vaginal birth. So I think, it was just our culture of course, a vaginal birth is safer. You're a great candidate. There's no reason, maybe it's your trauma. It's this. Can we help you? As opposed to saying, no, this is really what he needs. End of discussion. So I think it was a combination of our birth culture here, but also just misunderstanding the needs of a particular patient.
Right. And then just the next part is so this patient interview in this online module was followed by a lecture given by Dr. Hawkins. And these are just some of the key points for you to look at, but really Dr. Hawkins wanted to highlight that it's important to refrain from any assumptions of any of our patients, but definitely when treating transgender patients, and kind of avoiding gendered language, soliciting feedback, and assessing the needs of our patients. So you can peruse this on your own, but I just wanted to highlight that.
I know we're close to the end of time. Do we have a couple minutes for questions?
Oh yeah, for sure.
Great. If anyone wants to unmute or put them in the chat, please feel free to ask us questions now, and please feel free to reach out to me, to us, through the app or through email, however, for follow-up questions.
Hallie's got her hand up.
Hi,
Yes.
Thanks so much for this talk. I had been at a session earlier in the conference, like that first weekend. I'd have to go back to the agenda to see which one, but also talking about gender diverse patients and language. And there had been an interesting topic of conversation that came up, which was, so I'm very similar. I'm a clerkship director, and I've gone through, as I've had more transgender patients in my own practice, I've taken a look at our clerkship verbiage, and I've become very comfortable with saying, person and patient and they and folks. And somebody brought up, well, if we're constantly, referring to people as the sort of the vague impersonal they or them or patient or person, we are depersonalizing the way that we talk about patients, and it was interesting. And I said, well, when I talk to people in person, I'm calling them by whatever they want to be called by. But I do think it's appropriate in the note, or if we're unsure, to be, inclusive. But anyway, that came up, and I thought that was very interesting because it was sort of an argument against this, which I didn't agree with. But
Yeah, thanks for sharing that. And I mean, I definitely feel like, especially not entirely, but mostly amongst older, again, like I said, I'm over 50, and people my age and older often feel a lot of discomfort with these changes. And also people who were very involved in the feminist movements in the 70s and 80s and even earlier, women's rights, women, so, and just trying to reframe it for everybody that this isn't about losing those gains or not advocating for these populations. It's just about being inclusive to everybody who might, be subject to that same oppression. And so it's just a lot of reframing and being supportive. I like to call in and not call out, and just, I remember doing a prep session for a small group where one of our older volunteer faculty kind of was doing a lot of eye rolling when we were talking about the language changes. And to some degree, people sort of did self-select, like people dropped out, not a lot, a couple people dropped out of teaching small groups because they didn't like doing it this way. And I ultimately am okay with that. And I think just being open to these discussions is important. Sometimes people feel like they can't even bring up their concerns. So I try to be a safe space for people to come to me with their concerns about the language or their fears about making mistakes, so that you know, we can have ongoing discussion and learning. But I totally agree that not everybody is on the same page.
Thank you for sharing that, Dr. Cummings. I think one thing that I can share as somebody who is more new to the medical field is I found it really interesting that within OB/GYN, it really seems to be the only specialty that really likes to use the term women, or a really specific term that refers to their patients. Whereas in internal medicine, people say patients all the time. They don't say men and women. Maybe in pediatrics they say children, but not always, because you have children and teens and people who are 19 years old. But it's just so interesting that there's such a desire to hold on to the term women. So I think hopefully this is a piece that you can use to push back against the pushback, because no other specialty really, they don't say, oh, our patients with lungs in pulmonology. They just say our patients, or our breathing patient. You know what I mean? So I think that's something to think about as well.
That's a great point. I like that as an argument point. I think a lot of it does come, and the person who made that comment was an older man, self-identified. The other thing I do think that's interesting is the idea of like sort of the women's rights movement and those, hard fought gains. But again, I agree with you guys. I don't think it's exclusive. It's just bring more people into the fold.
The cool thing I liked about your guys' presentation was how you showed it. It's not like we're going to turn every single case and across the spectrum into persons, right? A great example you showed was just putting some pronouns she, her, and saying the patient self-identifies as a cisgender woman. The end. Woman, she, her, the whole entire case. And like you were saying, you can do this with individual people all the time. The patient says breastfeeding, you just say breastfeeding. But if a patient, comes to you and says, they're transgender, maybe you want to ask, how are we going to talk about lactation in your pregnancy? But then you just do it individualized, right? But you guys nicely showed. The one thing I loved was you didn't try to crowbar pronouns into your contraception. You just addressed it completely separately with a focus on transgender. That was awesome. And I'm taking that right away verbatim. That's amazing. Thank you. The one question, Monica, and I struggle with this, and maybe Naomi, you too. What are we going to call women's health? Like OB/GYN. What's the word? I don't know. I think a lot about this. Like, what is the word to recall our specialty?
Yeah,
Monica, you want to take that?
Yeah, that, I'm talking a lot with some of the experts here who are OB/GYN experts in trans health. And, we thought, well, we haven't created a perfect solution, but one is gender inclusive pelvic health. That is an alternative potentially. So, still ongoing, still thinking about it. But I think just at least the fact that we are thinking about it is the most important thing. But I really appreciate that question.
Yeah, I agree. And it sort of goes, to have an all-inclusive umbrella thing, I'm not so sure. I talk about reproductive health a lot, which also excludes some things. We talk about OB/GYN. Technically gynecology, the root of that word is woman, so OB/GYN. We actually changed my hospital, San Francisco General, our clinic is called the OMG clinic, which is obstetrics, midwifery, and gynecology. But again, that's not entirely non-gendered. And like I said, our labor and delivery is called a family birth center. So I think they're more inclusive than saying, women's clinic, which we used to call our clinic the women's clinic. So it's a work in progress. I think my sort of dream is that new terminology will be created and we'll solve a lot of these problems, but that doesn't happen overnight. So I think we find creative solutions in the meantime.
I had seen an email from SASGOG where they used this phrase that I bookmarked and that I really liked. So they said, furthering the health and welfare of women and gender diverse people cared for by obstetrician gynecologists. So it's like the reverse syntax, so it's like the people who are cared for by people in our field, so it's a little wordy, but I still liked it.
Absolutely. And I think, our department is revising our mission statement and considering terminology just like that.
Holly, I wrote that down when you said it after a session last week, and I updated our whole handbook. Anytime we talked about like woman, I changed the language to say women and gender, the way you said it. I like wrote it down and then I updated everything because I really like that language too.
Oh, that's awesome. Yeah, I stole it right from SaskGov.
So everybody, we are after our time, which is great because this is awesome, and we recorded even more. So you got plus minutes on a great presentation. Thank you. That was really outstanding. Thanks for wrapping up our FDS Friday this way. It was really great.
Thanks
Thank you so
everybody
much
for
for being here.
coming.
Thank you so much.
All right, everybody,
Thank
have
you.
a great everything. If you're in the bomb cyclone of where we are, enjoy your snow. Be safe, and if you're not, just have great weekends and be safe. And thank you for participating in FDS on FDS Friday and virtual. And hopefully next year we all get together somewhere really amazing. Have a great
Bye.
weekends. Bye.